Welcome to this next session, Ovarian Cancer from Beyond the Ovary, Perspectives on Science, Clinical Progress, and Advocacy. Thank you to our sponsor, Merck, for making this session possible. In this session, Dr. David Huntsman will lead a thought-provoking exploration of lessons learned and lessons shared, what we can learn about ovarian cancer by expanding our knowledge of other gynecologic cancers. Dr. Huntsman is the Canada Research Chair in Molecular and Genomic Pathology at the University of British Columbia and an expert in ovarian cancer. Thank you for joining us, Dr. Huntsman.
Hello, my name's David Huntsman, and I'm joining you from Vancouver. And I have the honor of being the scientific director of our ovarian cancer research team, which is a multidisciplinary team and multi-institutional team called OVCARE. And now we consider ourselves part of a larger initiative called the Gynecologic Cancer Initiative. I work at the British Columbia Cancer Agency, the Vancouver General Hospital, and the University of British Columbia. And today, I'm going to be talking to you about the things we learn about ovarian cancer from beyond the ovary, and with a focus on science, clinical progress, and then advocacy, because I don't believe that we can maximize our impact on ovarian cancer without embracing opportunities in other gynecologic cancers. This isn't the usual sort of talk I give, which are more medical or scientific, and so I hope you bear with me if it sounds strange or disjointed at times. So I'm going to describe first our own journey, how OVCARE went from being ovarian cancer focused solely to becoming a broader gynecologic cancer initiative, thinking that maybe there could be some lessons there for OCRA and the advocates and others who are listening who are part of the OCRA family. I'm going to talk about the first lesson from outside the ovary, an obvious one, how studying the fallopian tube led to an ovarian cancer prevention strategy, how we're from studying endometrial cancer and developing a much needed classification system that will actually impact ovarian cancer as well. And then the reasons to grow the Ovarian Cancer Research Alliance's mandate, research reasons, clinical reasons, and I think advocacy as well. This is what drew myself and my team members to study ovarian cancer. These incredibly depressing graphs which showed that the survival rates for ovarian cancer were much too low, horribly low, and also stable over many, many years. And our updated data shows a little uptick, but we're not where we need to be. So we needed to do better. We had a very inspirational leader of gynecologic cancer service for the British Columbia province called Dr. Diane Miller. And around 20 years ago, she called a meeting and just said she's just sick of seeing women die of this cancer. And maybe if we work together, we could do something about it. And so we met with Diane afterwards and said, yeah, we can do something about it. We'll form a team, we'll share resources, we'll focus on prevention through diagnosis, treatment, survivorship, and we'll be able to make a difference. And so we formed OVCARE. The first obstacle we faced is that it was very difficult to progress ovarian cancer research and clinical improvements because ovarian cancers were all treated the same way and were studied in a kind of mishmash kind of way in research labs because the subtypes of ovarian cancer weren't recognized. And this is a very depressing statement from 2017, basically saying that all ovarian cancers kind of treated the same way. The reason why this happened was because the classification system used by pathologists, such as myself, just didn't work. Pathologists were obliged to declare a cell type and then a grade or how nasty the cells look down a microscope for each case and call them accordingly. And this was basically irreproducible and therefore not usable, and it stalled all progress. Our team and others worked to crystallize the classification for ovarian cancer and show clearly that in research and in the clinic, these are very different diseases and have to be treated as such. This provided a platform for a lot of the progress which we've seen but each ovarian cancer is a different disease type, requires different solutions and different research approaches. The best thing about this classification system, it can be reproduced with a 95% accuracy by community pathologists without any help. And in difficult cases, you can sort them out by immunohistochemistry or other very simple lab tests, or through referral to gynecologic pathologists. These subtypes are basically different diseases. The low-grade and high-grade serous cancers tend to present at a much higher stage, meaning that the disease is spread further at time of presentation than the other subtypes, and their prognosis, if you look at many cases over many years, are quite distinct as well. In fact, every way you can define distinct diseases, distinct etiologies, precursor lesions, molecular characteristics, presentations, clinical courses, biomarker profiles, response to therapy, these are different diseases. So our team coalesced around the idea that if these are different diseases, if we treat them that way in research, and then ultimately in the clinic, we'll be able to make a difference. And so ovarian cancer has shifted from being a disease which was treated generically to a disease where there's a much more of a stratified approach. No one would treat a low-grade and a high-grade serous cancer the same way now, or endometrioid cancer and a high-grade serous cancer. These are considered different entities. For many of them, we don't have the solutions we need, but that becomes the focus of research. Endometrial cancer, of course, is still stuck in a totally generic space until very recently, and that's an opportunity I want to describe to you. So this was very liberating to show that it isn't, ovarian cancer isn't just a mess of cancers where some have a little bit of one flavor, some have a little bit of another flavor, but they're kind of weirdly the same thing, but it's a mixed bag. These are absolutely distinct diseases with hard lines separating them. Each histotype or subtype offers distinct questions and needs distinct solutions. And it also, this means that success, if something works in one subtype, there's no reason to expect it to work in another. For instance, platinum and taxane does have a great impact in most high-grade serous carcinomas of the ovary. It doesn't do anything with clear cell cancer. It's a different disease. You wouldn't expect it to. But if success isn't translatable between the subtypes because they're different diseases, failure isn't transferable either. So just because a treatment fails in one subtype, that data has no relevance for the other subtypes. So for instance, HER2 targeting was done in high-grade serous cancers which don't have HER2 amplification, but we do see HER2 amplification in about 20% of mucinous carcinomas which may respond. So we can learn from other cancers in a histotype-specific fashion. Clear cell cancer of the ovary has much more in common with clear cell cancer of the kidney than it does with any ovarian cancer. So we have to think about how we learn. It isn't just sticking in the ovary, it doesn't tell us what we need to know. And progress will be made in subtype-specific basic translational and clinical research. So this was the template we followed. We dug into the different histotypes using what was called next-generation sequencing, but this is now 12 years ago, and it's kind of old hat now, but found some of the key mutations in multiple types of ovarian cancer. And we were quite excited, and I must admit we were a little bit full of hubris as we found made these discoveries. Some of them could be rapidly translated into diagnostics, which was cool, and we hoped we could move quickly into the development of new treatments. But it's much more difficult than developing a diagnostic, in that you have to really study the mutations in cell systems which represent the cancer which you found the mutations in. And for some of these cancers, there aren't any model systems to study. So our efforts have moved to this. Also, mutations only tell part of the story in cancer. Finding the mutations in a cancer doesn't tell you what you need to know. Of course, the cancer occurs in a fully embodied human who lives in a world which needs consideration and may have other illnesses. And so you have to take into account much more than just the cancer. Even biologically, the mutation is just part of the story. We now view from just thinking about the mutations to the fact each cancer really represents an endpoint of a distinct oncogenic journey. And in any journey, let's say you're thinking of a hike, there's a place you start, a cell of origin. There's a terrain you cross, which is the environment the tumor is growing in, which is a key component. And there's what happens along the way, mutations. And so now we sort of consider these together, and we're building models where we can study these factors. And as we do this, it became absolutely clear to us for the fallopian tube and uterus are essential parts of ovarian cancer research. We have to be outside the ovary to understand what's going on in the ovary. And so as we came to this realization, we decided to do something a little different. We changed from being just an ovarian cancer focused team to a much broader initiative, which we call the Gynecologic Cancer Initiative. We still sort of keep the name OVCare because we like it, but it's kind of embedded within this larger initiative. The reason why we did it is the need to study normal and abnormal fallopian tube and uterine tissues is essential to understand ovarian cancer. Also, the same clinical team, research teams, and most importantly, patients who need and demand progress in endometrial cancer and cervix, vulvar cancers, they all meet in the same clinics and we work together. It's the same community. And we found there was complementary expertise in these other cancers types, which we could bring into the ovarian cancer space, which was really helpful. So we coalesced around a goal that if we pull together everything we can do in prevention through diagnosis, management, survivorship, we can decrease death and suffering from gynecologic cancers by 50%. And I find this absolutely motivating. It's a huge goal. So we have to invest in prevention strategies, diagnosis and treatment, survivorship, and we have to bring them together. But this goal of a 50% reduction is absolutely transformative in the way we approach everything we do. First of all, we have to have the breadth across the different types of research. Well, I can't do this. We had to expand our team and bring in researchers who are focused on survivorship and prevention, or much more mature in those regards than I am. We had to think about all gynecologic cancers, not just ovarian cancer, but think about fallopian tube, uterus, cervix, and cancer of the vulva, which is actually a very much a neglected disease, and yet could benefit from the same type of rigor which the ovarian cancer research community is showing today. The other thing, our goal of 50% reduction means we have to impact every woman and everyone in our population. It has to be across the population. We needed to build out our team because no researcher can do this. It's too much of a challenge. But that's been a huge joy to recruit and mentor junior researchers with different skill sets and bring them on board. And we have to engage many different partners, including our patient partners across the province, to make sure no one's left behind in this. And that's the only way we can achieve our goals. And I found this transformation from just being focused on ovarian cancer to a much broader initiative absolutely motivating and exciting. And it just sort of makes more sense in many ways. And I'm hoping that some of this will resonate with the audience. So the first obvious case of why looking beyond the ovary is valuable is the idea of where these ovarian cancers or carcinomas, epithelial ovarian cancers, come from. These are the carcinomas shown in red here. This is a textbook from the year 2000, which suggests sensibly that the closest epithelium to the ovary is ovarian surface epithelium. The cancers must come from there. A editorial written in or published in 1999 suggested that that's not where they come from. Now, this editorial didn't quite get it right, but it said that the way we were thinking about it was wrong. And I view that as a tremendously valuable contribution by Dr. Louis Deveau. And then a paper which really surprised a lot of people came out in 2001 from Peek and colleagues from Holland, which showed that if they look in women who have prophylactic ovarian and fallopian tube removal, and they never see things going on in the ovary, but they could find early cancers in the fallopian tubes. And a bunch of many groups have contributed to this. Christopher Crum being notable in Boston with Ronnie Drapekin, who's now in Pennsylvania, Patricia Shaw in Toronto. There's many, Yiming Shi and colleagues in Hopkins. These are real. And the case for these being the precursor lesions for high-grade serous carcinoma of the ovary just gets stronger and stronger. I mean, the genomic connections between precursor lesions and tumors has been shown by the Hopkins team and others. When we look at incidental cases, they're almost always tubal and not ovarian. But there is some suggestion that there may be some high-grade serous-like tumors which could come from ovarian surface epithelium from gene expression profiling studies and a mouse model. But the clinical relevance of this is not known at this point. But anyway, suffice to say, the majority of high-grade serous carcinomas of the ovary start in the fallopian tube or in fallopian tube epithelium. It's just some pictures of what these little lesions look like in comparison with the tumors themselves. And Ronnie Drapekin did lots of fantastic work on this, developing model systems. And this is just a cartoon from one of those showing how these lesions can develop and then shed into the peritoneal cavity and onto the ovary where the tumor develops and the clinical problems arise. Now, I must admit, when these papers came out, myself and some of my colleagues were also thinking, well, what would this mean to women with BRCA mutations? And that's important. And there's a couple of fantastic trials looking at that in terms of doing fallopian tube removal before ovarectomy. But Diane Miller, our head of gynecologic surgery, is an incredibly imaginative individual. And she said, no, let's think about the general population. The 80% of women who don't have a BRCA mutation who have one of these high-grade serous cancers. So we looked in our records and we found, sort of to our horror, that about 20% of those women had had hysterectomies done previously to their presentation with ovarian cancer, and their fallopian tubes were not removed. And so Diane posited that if we remove the fallopian tubes of women at time of hysterectomy or tubal ligation, we will prevent a large portion of high-grade serous carcinomas of the ovary and also clear cell and endometrioid carcinomas, which pass through the fallopian tube as endometriosis before they become cancers in the ovary. This was a really exciting idea. We presented this to our community after discussion and realizing this would be a safe thing to do. And with advocates as partners, worked with our gynecology community, the general gynecologists, and said, please, will you change practice? It wasn't a demand. It was like, we think this is an important thing to do. But we have a very strong relationship with the general gynecology community. And fortunately, they complied. We believe that by removing fallopian tubes at times of these surgeries, we can reduce ovarian cancer incidence by about 30%. And we think this is definitely worth doing. Some professional organizations came on board very quickly. This is just from the Gynecologic Oncologists of Canada, and who recommended it. It's kind of not a strong recommendation, but it was recommended, but it should be considered. But there's lots of questions. Is it possible to change practice? Is it safe? Will it work, and to what degree? And these are really important questions. In fact, nobody thought we could change practice when we suggested this, but this chart shows we definitely did. When we started, when a hysterectomy was done without ovarectomy, the fallopian tubes were removed 6% of the time. By 2017, 80%. For tubal ligation, basically fallopian tubes were never removed in 2008. We're up to 75% by 2017. Big practice change. So there's practical aspects. We can change practice, but safety. We'd shown that there was no discernible increases in hospital stay, blood transfusions, or anything else by doing this. We've also recently shown that there was no change in menopausal symptoms or treatments as well, which is really important because that was raised as a concern, and that paper's just come out. But does it work? So there's hints from retrospective studies that salpingectomy reduces the incidence of ovarian cancers. But these studies were not controlled for why the salpingectomies were done, as opposed to being done as opportunistic salpingectomy at the time of other gynecologic cancer surgeries. We now have data which was published this year in JAMA Open Network, where we looked at the expected cancers calculated using age-adjusted rates from a control group of women who had hysterectomies with fallopian tubes left behind and traditional tubal ligations against women who had opportunistic salpingectomy or fallopian tube removal at the time of their surgeries. And we expected that we would see 5 serous carcinomas, and we saw none. These are very early data. It's the beginning of a wedge effect because these women are much younger than their peak incidence for ovarian cancer, and we expect the numbers in this small cohort are just going to keep growing. We're also working with the global community through a project called the Ovarian Cancer Observatory to look at the impact across many centers. Just to make sure we weren't looking at some sort of strange artifact, we asked the question, did we also see a reduction in breast cancer or colorectal carcinoma, which would make no sense, and we did not see a reduction. So this is an ovarian cancer specific phenomenon, which is real. So that's good news, it works. The bad news is, even in Canada, the uptake is highly patchy. Sadly, between 2011 and 2016 in Canada, and we've got about 1/10 your population, and multiply everything by 10, 200,000 Canadians missed this opportunity. They had their traditional surgeries without fallopian tubes removed, based on a 1% incidence of disease, 80% estimated preventive effect. That would lead to 1,600 death cases and up to 1,000 deaths from this disease, which could have been entirely prevented. So we must do better. So in summary of this, opportunistic salpingectomy, prevention of ovarian cancer, can work. It's safe. You can have a high uptake. And we believe medical equipoise surrounding this is shifting, but advocacy is needed, and we hope to work with the Ovarian Cancer Research Alliance on this. Now, this was about outside the ovary, so I want to do a shout out and thank the fallopian tubes, which is obviously a ridiculous thing to say, but and I apologize, my slides are automatically progressing for reasons which I don't understand, and so I would just have to keep adjusting. But thinking outside the ovary led to this tremendous advance, which I believe is one of the most important things which has happened in the ovarian cancer space in the last 25 years. And so it's just an example. The next example starts in the uterus. Now, the classification of ovarian cancer works. When pathologists classify these different types of ovarian cancer, it's a very accurate diagnosis and it can be used. And then everything, all the molecular analysis we do starts from that point. But in uterine carcinoma, it just doesn't work. The best pathologists in the world can't agree on what cases of which type of uterine cancer. So there's no solid platform to build from. Uterine cancer compared to breast cancer is actually, this is increasing in incidence. There are more cases every year of uterine cancer. The portion of deaths per cases is pretty much the same as breast cancer, but it only gets 2.5% of the funding in Canada anyway, compared to breast cancer, and I'm sure the portions are pretty similar in the States. So this is a really unforgotten, unstudied disease. As I mentioned, we don't have a pathology platform to build from because the best pathologists in the world can't agree on, when they look down a microscope, on what they're dealing with. This leads to imprecise estimation of the risk of recurrence, almost randomly selected treatments for patients, and it's resulted over time and everywhere with both overtreatment of some patients, like patients getting intensive treatment when it's not going to do anything for them, and undertreatment in many other women. And this was where we were. Very, very difficult and depressing position. And a paper came out for the Cancer Genome Atlas, a large genomic landscaping study led from the United States, which showed that you could classify endometrial cancers into 4 groups based on molecular data. And these groups had very distinct prognosis and different molecular features, different characteristics which could be targeted. But noteworthy, there was about 10% of cases which look terrible down the microscope, where the women do stunningly well, no matter how they're treated. And so these women tended to be overtreated. And there are other patients who were undertreated, which is also very problematic. Our team, in this case led by Jessica McAlpine and Aline Tehouk, have led the development of a pragmatic classification based on this, where it's just based on simple things any lab can do, immunohistochemistry and a little bit of sequencing, you can sort out these cases. A similar effort was led from Leiden in Holland, and the results are very similar. This, you can do it on biopsies, you can do it on surgical specimens, and you get the same prognostic effect. There are these blue patients, the polymutated cases do fantastically well, no matter how they're treated. And then a group in red who have a much worse prognosis, and we really have to develop much better treatments for them, and they should be the focus of more basic research and translational and clinical trials. This has been shown across multiple cohorts. We see the same result again and again and again, shown in other countries. And later this month, I believe the NCCN are going to come out more strongly with statements around this. And this will be a focus of the International Society of Gynecologic Cancer and their major meeting in New York. So what are these groups? Well, we have a group with poly mutations, which tended to look bad down a microscope, but women do tremendously well. We have a group with mismatch repair defects. These individuals need referral to cancer genetics, but they also, if their disease is metastasis, may respond to immunotherapy. We have the P53 abnormal group, which are the most aggressive. We need new treatments for these. And there are some really interesting trials starting to develop in this space, because now they're focused on where they're needed in a much more precise fashion. And the P53 wild type is called NSMP. That's kind of a non-specific large group. We're starting to dig into it to see how heterogeneous is this. Is it one group, or can we break it up further and end up with a very good prognostic group and something in between which needs more attention? That's an area of active study, but we have a framework to move forward with. The same way ovarian cancer research and care leapfrogged after we had the pathology classification was settled. This provides a way to move forward. So now clear cell and endometrioid ovarian cancers come from uterine tissue. They come from endometriosis. There are about 20% of cases in North America. I mentioned clear cell ovarian cancers shown on top. They're sort of like kidney cancers, but in the wrong place. And there's many groups who are studying these and trying to develop new treatments. The endometrioid cancers are less studied. But what's interesting is these are basically just like the uterine cancers in the uterus, which are a much more common disease. And recently, a paper came out this year, which showed that the same uterine cancer classification system, which is developed for uterine cancers, works just as well for cancers of the uterus, of the ovary, endometrioid cancers of the ovary. So we're can take something which was developed for cancer of the uterus and use it in the ovary to classify these cases and determine how to treat them. And you can imagine if clinical trials occur, these patients should be connected with uterine cancer clinical trials, because the same classification system and treatments would be tested. So just another example of how bringing these diseases together, there's great benefits, not just outside of patients who have these other gynecologic cancers, but also for the future for ovarian cancer patients. So reasons to embrace uterine and other gynecologic cancers from a clinical and research perspective. Effective ovarian cancer research requires consideration of fallopian tube and endometrium. Some ovarian cancers are basically endometrial cancers in the wrong place and should be studied and treated as such. And this is really emerging right now with the use of this endometrial classification system in ovarian endometrioid cancers. But when you look at who's working on these, it's the same clinical and research teams, and the patients meet in the same clinics. It's the same community. I think there's a massive opportunity to rapidly progress endometrial and vulva cancer research and care using the same kind of team approaches, which have really worked well in ovarian cancer. From an advocacy perspective, uterine cancers are more common than ovarian cancers, but the patients do not benefit from the same degree of advocacy. I don't know why that is, but there could be great benefit in powerful groups who are really good at advocacy, like the Ovarian Cancer Research Alliance, engaging in this. I believe that broader gynecologic cancer education efforts may be more impactful than the current piecemeal disease at a time approach which we take. and it would be better aligned with practice groups and professional organizations and clinics as well. And so I think there's some the ways to boost the impact of our advocacy work. And if groups like Ovarian Cancer Research Alliance don't engage, then there'll have to be endometrial cancer groups emerging, and it would just confuse to have multiple organizations with kind of conflicting agendas, as opposed to powerful organizations taking on broader mandates. So I'm hoping that this talk may have interested, may have raised some questions and comments, and perhaps produces some discussion amongst you all. I want to thank you for listening. Very grateful that the Ovarian Cancer Research Alliance invited me to speak. And I apologize if people were expecting a more scientific talk, because what I really wanted to do is just make the case that I think that we need to think a little outside the box to take the next step to help future patients with ovarian cancer and maybe prevent people from ever becoming patients. So at this point, I want to thank my team and collaborators and funders, and I hope that the rest of your meeting goes well. The agenda looked really exciting, and if there are any questions you'd like me to address, I'll be happy to attempt to do that. So best wishes, and enjoy the rest of the meeting.